Rich, how you doing?
I'm doing great, Mark. How are you?
Good, good. So let's just remind everybody who you are, past chairman of the restorative department at UCLA, the
That's
biggest
right.
department in the dental school, I think the best dental school in the country. And now you have a teaching institution. You dedicated yourself to teaching courses, and I know you're all into Airway now, so that's fantastic. Having you, of all people, be involved in that.
Right. After 26 years in academics, I started a teaching center and private practice here in San Dimas, California, somewhere between uh, Ontario, California, and Santa Monica. We're sort of nestled in that inland area, and it's fantastic. I've been here now for about 8 years.
Good, good, good.
So remind
And
everybody, Mark, your shortened curriculum vitae.
yeah, yeah, I know. So I'm just a regular dentist that's been involved in this airway phenomenon the last 15 years and teaching these courses. Really the only one with Barry Rayfield that in the country that was teaching comprehensive courses in the form of the Airway mini residency that at the time everyone was focused on sleep group solutions and appliance therapy. And so I'm so happy where we are now that so many people have jumped in and opened their eyes about what Airway is. And we've talked about what it actually is, and we know what it's not. But I thought today that we could discuss an article on a study that came out a few months ago that is, I believe, seminal in many regards in that it comes from the otolaryngology community, the medical community, interdisciplinary team of researchers from Boston, Brigham, Missouri, Brigham and Women's Hospital, University of Maryland. It's a pretty heady cohort, and their study was upper airway volume, stating that upper airway volume predicts brain structure and cognition in adolescents. And I just find that so exciting and interesting because it underscores from the medical community what I've been teaching for 15 years, that
Right.
people thought I was crazy.
Yeah.
What is the airway and the dental structures that surround it have anything to do with all these medical comorbidities? And that really is central to what airway focused dentistry is. It's the medical indications, not the dental comorbidities, but the medical indications of why we would even recommend a dental intervention. And so I wanted to talk a little bit about that. I know I sent you the article as well. What did you think, Rich?
Yeah, well, I've read the article, and just for everyone out there, the article is published in the American Journal of Respiratory and Critical Care Medicine, and we can provide a reference on the screen. With that, it'll pop up now. And the name of the article is Upper Airway Volume Predicts Brain Structure and Cognition in Adolescents. It's a major paper, has a significant, as you mentioned, pretty sophisticated cohort of investigators from Harvard, from Johns Hopkins, and people that are on the cutting edge of this this area of investigation. Uh, I I read the paper with significant interest, but at the same time, having been trained in airway, it's no surprise for you having been, you know, basically shouting this from the hilltops
Mhm.
and providing excellent documentation for all of this that has been in the literature, albeit maybe not as easy to find, perhaps, maybe. You've been saying this for a long time, Mark.
Yes.
And if you go to the Airways mini residency, you learn this in the first day, and then it just all the principles get reinforced, and
Yeah.
so on. But now we have the medical community stepping up and writing a rather courageous article, quite frankly. And they basically say, look, here are the facts. And the bottom line is, a lot of our kids, a lot of them, and I think they underreport the actual number of problems, but a lot of our kids are really experiencing significant problems as a result of untreated airway issues. Significant problems. And it's scary. And I think that we have, we have a relationship between airway volume and cognition, utilizing world-class tests to score the kids in the different categories, and the correlation is extremely strong. This is undeniable evidence, and this is going to it's going to hopefully disrupt a lot of people right now into thinking a little bit more seriously about this. I mean, the first question, if I were a pediatrician, I would ask the parent and the child was, how are you sleeping? How are things going with your breathing? I would focus on that part of the questionnaire. I would. And it's really interesting when I ask my dental patients those kinds of questions, they kind of look at me a little, that's an odd question. How am I feeling? How am I doing throughout the day? And all these kind of things. Wow, what dentists don't ask those questions. In fact, my doctor doesn't even ask those questions. And then it opens up a whole discussion, of which you've got so well polished, and you've done so many of those interviews. You have such a very sophisticated way of doing that. As a relatively new person on the block, I'm doing the best I can, but I would love to discuss this article with our listeners in more detail, because this is one of those things that every dentist that's interested in airway needs to have read this article. And I believe
Yeah,
it'll be very helpful.
absolutely. Yeah, absolutely. And certainly if we got into the details and maybe at the very end, we'll talk about it. It's not so simple of just asking about how they're sleeping, because it's so subjective. Oh yeah, he sleeps just fine. And you find that most parents don't
Right.
even in this
That's
study,
right.
it was even brought up that most parents don't even stick their head in their kid's room. But the
Correct.
primary aim of the study was to assess the relationship between MRI derived upper airway volume in children's cognition. And what they did is they used the adolescent brain cognitive development study that was, they call it the ABCD
Yeah.
study, that looked at a baseline cohort of at least 12,000 kids. And they used a very sophisticated battery of cognitive studies, visual, audio. It was like 6, 7 different studies. So they did a lot of
Right.
cross-referencing that evaluated crystallized and fluid intelligence. So there are different types of intelligence, as Raymond Cattell defined way back in the day when he came up with the IQ score. There are largely two type of recognized intelligence. So fluid intelligence is the type of intelligence that you have very, very early in life, which is you can memorize numbers, you could see things and remember and recall very, very quick. And so that peaks in the late teens, and it starts um, decaying around 2021. And crystallized intelligence really starts peaking in many later years, in the later decades. And what's crystallized intelligence? Crystallized intelligence is really, let's just summarize in one word. It's wisdom. And so it's basically learning how to take information garnered from fluid intelligence and connecting relationships and making complex decisions about them. And so, you may lose that ability to memorize things like the songs to lyrics when you're in your 30s and 40s, where when you're a teenager, you hear a song once and you know all the lyrics to it, right? You see these kids out there, singing all the lyrics of the songs. And
Exactly.
so that's just an example, but they studied those types of intelligences. And the bottom line was that they found that smaller upper airway volumes increases this exposure to hypoxia that damages those specific areas in the brain that are related to cognitive and emotional function. The prefrontal cortex executive functions, being able to restrain your impulses, impulse control, and things like that. And so we know that teenagers don't have that emotional maturity till later, or some of them would argue that for us males, it's not till our 40s that we get a good handle on that. But this study was really fascinating because the way it was designed and the amount of time they actually use machine learning or AI, what they call deep learning, in looking at the various slices of the MRI. But they're saying it's the first study. Actually, it's not because Gimeno and Kushida out of Stanford in 1997 actually used a morphometric model that had a very high predictive value and a low negative predictive value. In other words, it was very, very specific, had good sensitivity, good specificity, had, I believe it was something like 100% positive predictive value and 88.5% negative predictive value. When they looked at palatal width, height, they looked at all these metrics and they published this, and it was largely ignored. Um, some maybe 10 years later, um, medicine actually did use the lasers looking morphometrically at the oral cavity, kind of like what we look at as dentists. And that was the first time I said, hey, these are physicians going in and looking at these dental structures that we look at all the time. And they came up with a study to morphometrically evaluate risk for breathing. Valiant effort, but ill-conceived if you know what you're doing, because it had a lot of problems. But what I was excited about is that physicians were actually recognizing things that we had been talking about. And so this study now, fast forward 2025, um, uh, with a rather large sample size, is actually saying what we've been teaching for 15 years now, that you can really quantify even better than the quote unquote gold standard sleep study. And the study actually looked at some of the problems of the sleep studies because of access to care. The problem is so pervasive, although they did cite that 17% of children have sleep disordered breathing. I'm going to tell you that's way underestimating the problem, because there was a report that I was listening to earlier this week that said 77% of kids don't sleep well, right?
Right.
Okay, so we could talk about a lot of reasons why that is, and maybe it's not sleep disordered breathing per se, but there's sleep fragmentation that
Correct.
results in the same exact symptoms.
Exactly.
And so I thought this study was good in that way. Some of the problems that I thought it's very interesting. And I'll just say that I was just less than an hour ago, I was on a Zoom call with my good friend David Hatcher, and we were reviewing a case.
The
And
radiologist.
what's that?
Radiologist. Yeah, he's a dental radiologist.
He's a dental, oral and maxillofacial, probably the most recognized peer review oral maxillary radiologist in the world, certainly in North America. He's been in, and he also has worked with the veterinary and medical communities. He's a published author in a number of textbooks.
Right.
His hundreds of published studies. So really respected oral and maxillofacial or oral radiologist. He's the one that started beam readers.
Right.
And so I told him about this study because I asked him to write one of the chapters in my textbook on Airway, and he of course graciously accepted. And so in the textbook, we kind of have do's and don'ts of what to do. But he's looking at the use of CBCT through dimensional radiography. He also is an expert on MRI as a radiologist. And so these physicians are using an MRI. Um, we're using CBCT. We have the advent of using that, which is low cost. It could be accurate if you standardize it to do what this study says it's doing. It's actually measuring the upper airway from like the turbinates down to like the epiglottis, looking at the airway, something we've been doing for a long time. But we were using CBCT, but that's only one data set. So
Right.
what we do is we also look at sleep screening. We do a pediatric sleep questionnaire. So they actually have a pediatric sleep questionnaire that's looking more at snoring.
Right.
which is great, but I think it's still not as sensitive as some of the pediatric sleep questionnaires that we advocate that are validated. So there are some weaknesses in the study, but nonetheless, what's exciting is that the physician community, medical community, can't really fight us dentist so much about, this turf, if you will, because I argue that the facial skeleton is in our domain as dentists. It's just that we shoot ourselves in the foot when we just focus on the arrangement of teeth and dental crowding, and we're not looking at the soft tissue. We're not looking at the airway that really defines it. So anyway, I thought this was a really interesting article. One of the things that they said is the habitual snoring was associated very, very specifically with, in comparison to non-snoring kids, as a function of the volume of the airway. And of course, that makes sense.
Sure.
One other problem that I have that I think it's less having to do with the volume. And of course, we know it has more to do with the constriction or the kink in the hose, right? The starting
Right.
resistor, of
Correct.
which there are two. So they're looking at it more holistically. They're looking at it maybe the way we were looking at it 10 years ago. But it's certainly a really good shot over the bow for the domain of healthcare in general, especially when you know what's at stake. We're not worried about how the teeth are arranged. They're worried about IQ, brain development, behavior, and those very, very important comorbidities, which I say is really what should be driving, as dentists, should be driving our treatment plans. It shouldn't be the size of some intermolar width or crossbite.
Right.
We're too mechanical. We need to be more medical or physiologic, if you will. I mean, we're trained in it, but at the same time, we tend to be more mechanical anyway. So I
Well,
can
you're
go off on
absolutely
that.
right. Yeah,
Yeah,
I wanted to throw in one more thing about.
please.
I recently had an MRI, and first of all, you're talking about usually several $1 million for an MRI machine. Uh, the time it takes is 20 to 30 minutes. You have
Yeah,
to be completely still. You're put inside of a tube, which a lot of patients have a hard time tolerating. So, and then the cost for a 25-minute MRI in Southern California, because I paid out of pocket for this procedure to look at my shoulder, was $1,500.
yeah,
Compare that to what we almost take for granted these days with CBCT. We can be done with a scan in a matter of seconds. It can fit into the corner of our practice pretty much anywhere. And almost every dental office could easily afford a CBCT machine. And pretty amazing screening and data gathering methodology that we have. So yeah, we're I think we're positioned in the right place to get really great information. On that note, quickly, I just upgraded my CBCT. You'll be happy to hear that, Mark, because we do
large
conduct all
field.
our. Yeah, I went to
Nice,
the largest field of view that we could get. We're building a whole new room for it, so really, really excited. So no more,
nice.
having to make arrangements with some of the mobile services, which could be great, but
Yes.
also, it poses another potential barrier to getting things pushing
Yeah,
forward.
if you could control it and you have that consistency in the
Right.
same environment where you have like the laser pointer and you can
Yep.
keep them, that's great. We've been having a lot of problems. I'm excited to be moving in January to our new location where we'll have a CBCT as well. We're
Wonderful.
using the trailers, which are convenient for the patients because it goes to their home. But the problem is, and we've
Right.
been talking to the owner of these two different companies that are doing this, is there it's a different tech every time and they don't understand, and so there's a lack of consistency, or they cancel or they don't show up. And so I mean, they've been responsive and say, well, we're not going to charge you, we'll go over there, but it does muck up the workflow, if you will. So if you can
Absolutely.
control it the way you're
Exactly.
doing it, I think that's great.
Yeah.
But the other thing is also about the study is that they're not quite understanding is that so let's look at the authors. you have the otolaryngology, you have two neurology groups, if I remember correctly. Let me think. You had
Yeah.
behavioral, it's like a psychological group. They had sleep medicine involved. So it was a pretty uh, wide swath of disciplines that were involved in this particular
Even
study,
surgery too.
and surgery, right?
Surgery and radiology, nuclear medicine,
Yeah,
pediatrics. So
yeah, the pediatrics,
this
a
is
lot of
really
disciplines, a lot of
quite
disciplines, right?
quite
But they all miss. So what we talk about again in the mini residence, what we've been teaching is you got to look at structure, function, and behavior. So they're
absolutely
looking at just structure and
right.
making a lot of assumptions
True.
because as Krista Guilleminault would say, is you can have a small looking airway that functions really well or a really big one that's very collapsible and of course everything in between. So we have to also look at the function of the neurology of it,
Sure.
which could be anywhere from the collapsibility to the position of the tongue, the various cranial nerves, and this is in our wheelhouse of what we look at. So when I'm making an assessment, I don't ever look at one data set in isolation, just the CBCT or the SEEP screening or the
Of
pediatric
course.
screening,
Well,
right?
can I
Well,
jump in
please.
because it's like you got to be careful, dentists that are listening out there, when you deal with the sales representatives from the CBCT companies. They'll like to show you a beautiful rainbow plot of the airway in 3 dimensions, and they say there, that's airway, and I just I used to think, oh wow, that's great, how that's so valuable, and now I'm looking at, okay, that's one piece of information. We have so much more data that we need to collect, and if you're in the camp of looking at just cross-sectional areas or volumes of airway, and you're making your decisions just based off of that one data set, I think you'll find that the more you learn about this, that's just one of many things that you're going to need to base all your decisions on. And if you just simply were to just rely on that, and then they call it airway module done, probably we could revisit that and look at maybe there's a more sophisticated approach to this that'll provide you with, ultimately more targeted, more customized treatment regimens, and hopefully better results. So I've really
Wait, yeah.
just
So the,
yeah, I've just been really excited about understanding that if you always say this a lot, Mark, is the medical model, the medical indications for making recommendations based off of multiple data sets, and understanding how to interpret those to suggest possible interventions. So
yeah, in summary, what you're basically saying is we want to increase our sensitivity and our specificity.
that's true.
We want to we want to have the best, um, uh, the highest sensitivity, which has to do with um, a positive predictive value, and specificity, which is, in other words, we want to have our true positives be very high, and our false negatives having to do with specificity very, very low. It's what's
Correct.
called uh, area under the curve, the rock curve. We want to have that as close to 100% as you can. Obviously, if you
Absolutely.
get into the 90s, and how you do that is by cross-referencing different data sets
Right.
and just going through the process. So that's what we teach is how do you first compile the data sets, quantitative and qualitative, and put it together to where there's a high degree of comfort that we understand that what we're recommending is going to address it. And then, of course, we measure our outcomes. And the outcomes, again, are measured based on looking at the medical comorbidities. The interesting thing about this study was that the most robust relationship that was observed was between airway volume and the total cognitive composite score that they came up with.
Mm-hmm.
And it doesn't really surprise you if you really understand the studies that we talk about and review in the Airway Mini Residency that has shown that even an innocent snore actually causes loss of gray matter in the developing brain. And when you start understanding that's your kid, as it pertains to ADD, ADHD, most of the time we already know that sleep fragmentation. It's not a frank neurologic condition. So the ramifications of this study to me are exciting in that it actually says, yeah, this is really a real problem, and that maybe instead of having a first line intervention with Adderall or Ritalin, if it's your kid, you want to maybe think about how are they sleeping and of course breathing as a result of that.
Wait,
So
before you go further,
yes,
is because you mentioned it, and I want everyone
please.
that's listening to understand when you said a lack of gray matter, and I know oftentimes that's used in sort of a jargon way, kind of casually. Oh, I need more gray matter, or as a lack. But actually, in this paper, can you explain a little bit about the volumetric differences in the temporal lobe? They
Uh,
basically, we're talking about actual reduction in the size of your brain,
yes. And
documented smaller brain segments in the area that they targeted. That is serious business.
yeah, yeah. And in this particular study, they looked at the different areas and they actually isolated. So their summary was there was very weak association when you looked at the brain in toto.
Right,
But when they actually honed in on certain, like the cingulate, I can't remember all the different structures. We know the prefrontal cortex that's involved with
right,
executive function. But again, this is nothing new because Ron Harper at UCLA and Kumar 20 years ago were using diffusion tensor imaging from the UCLA Brain Research Institute. They were using functional MRIs looking at that point on adults that suffered from obstructive sleep apnea as an end stage. And they were actually showing that the right side of the cerebellum got hammered early and often from chronic intermittent hypoxia and
right.
knocked out selectively what they call an asymmetric injury to the right side that basically knocked out the sympathetic side of the autonomic nervous system. And that's why they had high blood pressure because it was unregulated by the where you have the left side that gives you the parasympathetic side. They balance each other. That was disrupted, but they also did studies showing that the mammillary bodies, the hippocampus, the insula of the brain were all damaged selectively, not only from the chronic intermittent hypoxia, but the reperfusion ischemia. So if you think about what happens is if you snore or you stop breathing, momentarily what happens is the supply of oxygen is stops.
You're talking about
So
ROS and the
you
oxygen
get reactive
filtration.
oxygen
Yeah,
species
yeah,
and that creates this whole cascade. So right now, just guys, as an aside, right now I'm writing a chapter for the Newman Carranza textbook with two other periodontists on the perio textbook. And my emphasis on it is really looking at the inflammatory response, the global inflammatory response from sleep disorder breathing, and then the local inflammatory response from the periodontal tissues that also have a systemic effect. And there's this crosstalk between both. And so the question is, which comes first? And if you're a periodontist and you're dealing with periodontal disease, you know, they've been ignoring or not even asking about the sleeping. Now, after this chapter, I think standard of care will be that you actually have to screen because, as it turns out, the odds ratio of having a periodontal condition is much higher that you have sleep disordered breathing.
hey, in
So
that,
if you're treating that, you've got to start asking
right.
the upstream problems. So I didn't want to digress too much into that because that could be another podcast, but it affects every discipline in our profession. Yes, I'm
Right.
sorry.
I mean, and in that chapter, do you delve into this to the structural findings too, and their relationship to, uh, a lot of periodontists are dealing with structural findings like, let's just say, recession or mucogingival
Yes.
issues, and they're doing a lot of periodontal work in those patients that actually the etiology, which is attributed to multifactorial, whether it be toothbrush abrasion and occlusion and all these issues, abfractions, things like that. We probably believe that there's a significant number of those patients that end up that way, having nothing to do with those those common diagnostic categories. That it is, in fact, the teeth were expanded out of the bone at some point. The bone is very thin on the buccal due to maybe an orthodontic approach, and so I think that the whole structural part, in addition to the inflammatory part, needs to be addressed. And our periodontists are they're kind of the internal medicine providers of our
Absolutely.
profession, and I believe it's perfect for them to be deeply involved in this. And it's a digression, Mark, but at the same time, I think it's important for our GPs out there, prosthodontists, orthodontists that are listening, to really understand the importance of having a well-trained periodontist and your team that understands all of this in order to better treat your patients. And
Yeah,
I think it's
absolutely. And
fantastic. I mean, this that could be the chapter of that book.
well, it's
Really.
my goal, because you're right. They are the internists, and so I invited two other very well-known periodontists that will be co-authoring, and I'm asking them to really focus more on, the surgical part of it, in that area of their expertise, because I'm focusing really more on this whole. But to answer your question, so the structural part. There are a number of things. Yes, iatrogenic is definitely, no question, a risk factor. We have a whole generation of patients that have had teeth extracted and retracted. But let's just think about the whole argument that the orthodontic community's had about it, that has no relationship. We know from growth and development that the way the face grows is through the dental alveolar complex. So those teeth actually pull down and create the bone as they drift downward. If you start extracting, there's going to be that dieback that's been well documented. So yes, that's one. The other is the anthropologic risk factor, which we would talk about in another podcast, that we know that our faces have materially changed um, uh, completely since the Industrial Revolution, say the medieval period. Of course, Robert Corcini wrote a textbook about that.
Yep.
But I'm actually getting into the inflammatory crosstalk of what's happening at the level of the attachment, which the chronic intermittent hypoxia from the sleep disordered breathing, and the metabolic dysregulation, that actually uh, upregulates the environment in the base of the pocket. So, for example, intermittent hypoxia has an anaerobic environment at the base of the pocket that allows for the biome to shift more towards a gram negative, from facultative to strict anaerobe. Those are the most pathologic, virulent bugs. And so you're favoring them by that hypoxia. I'm actually getting into, and I'm going to put all the different cytokine cascades, one ILB, TNF alpha, the rankle,
Yep.
MMPs that are upregulated. So the rankle pathway, I'm going to break down the whole rankle pathways that actually upregulate osteoclastic activity and inflammation at the site of the alveolus.
Right.
But it's cross-talking with the inflammation that comes from the intermittent hypoxia, and is actually adding fuel to the fire. So they're two separate, but at the same time linked processes that are highly associated, and that even when you're going to do surgical intervention, there are going to be recommendations on what labs you would do to favor a more favorable host response to the surgery. So one of the things that I'm also looking at is I'm making the distinction between hypoxic and non-hypoxic driven inflammation. They're different, right? So the hypoxic is from an OSA patient. The non-hypoxic is from the UARS patient.
Opioid
And
resistance syndrome, right?
yeah,
Yeah.
so that's very interesting anyway. So we kind of digressed a little bit, but the point is that we as dentists have to really be less mechanical and really understanding what's happening at this level, not just what we're seeing mechanically. Like
Right.
if you look at the horizon, you're by the beach and you look at the horizon and you say, yes, the earth is flat because it looks flat to me, not really looking at the big picture that as you go back, you can see that it's a sphere, right? And so we sometimes just look at what our eyes can see. You only treat what you see, and that could be dangerous, right? So that's
Absolutely.
that's what the airway focused dentistry is about, is really kind of stepping back and understanding a more global way of how we're seeing the host, the patient that presents with us and our treatment plans in an interdisciplinary approach, a truly interdisciplinary approach.
Right.
So, anyway, so very interesting.
It is very interesting, and I guess one of the things that I had to initially wrestle with, but now I've come to terms with it, is that I'm more leaning towards a pros type of a practice, reconstruction and aesthetic dentistry, things like that. Not to say I don't occasionally do single tooth dentistry, because I mean that's great. That's really predictable and fun and all that. But the last thing I want to do is take on a bunch of kids in my practice. The pediatric community belong in the pediatric practice, and what I've found through the airway, uh, I guess you could say my journey, has been that I, it's an imperative. I have to do it. I have to. I have to go younger. I have to go into the family, to the youngest kids, and even to the mothers that are expecting mothers. And I think it's and so when I read an article like this, I used to be a little bit less interested because it's a pediatric article. I get it, whatever. That's their baby. But now I see it as in a whole different light. And what we can do as dentists is so much greater than full mouth rehabilitation, single tooth meticulous dentistry, all of prevention, all of that stuff that we're so focused on. And we're missing, like as you mentioned, um, in many respects, we are flat earth believers. And I hate to say it,
Yeah.
it sounds, like I'm putting our profession down, but I can tell you guys, I'm one of them. And I've come to understand when we can step back and understand, we don't know what we don't know. And once you get exposed to see more things and understanding what they mean, um, it's quite a pivot in the way I'm approaching my practice. I'm
That's great. It
also,
makes me so happy to
right,
hear
Mark? I
that.
mean, you kind of hinted that I should really look at this, but you didn't push me. You kind of, I think you understood that Rich is going to figure this out,
Yes.
and I can tell you, I figured it out.
Yeah.
You've got to start young because truly, that's where we can make the biggest change, and we can. I mean, we cure the problem. We can cure it,
Right.
rather than let it end up in our
Rather than
aging
manage,
population with horrible, horrible sequelae, horrible. And we're not going to get into all of the documented problems with OSA, but I think most of the public that even have a CPAP don't even really understand what those problems are. So it's a huge area
right.
that needs to be addressed. But we're looking at what can we do to keep people from that. It's not inevitable. You can intervene and stop that from happening. All of the things that we've talked about in previous podcasts about the environmental effects and soft diet and the way we rear children and on and on, we can provide children and parents with a way to reverse that, or at least to stabilize. And to me, that is our true potential to
Yeah.
affect uh, uh, I mean, a major impactful change in the health of our families and our children.
Yeah, I agree. And I think well stated. I would say is you have to first understand, regardless of what you do and what specialty and what silo that you choose to be in, recognize and understand the airway timeline, what we call the airway timeline that we go through in a lot of detail in the airway mini residency. And what I had learned, prior to that, 20 years, 25 years, um, like you, Richard, my practice was focused on periopros.
Right.
As a general dentist, but I focused on my literature consumption and my study groups and my training on pros. And in fact, when I did decide to go into pros, I was interviewed by the head of grad pros at UCLA, and she said, "Why would you want to at this point? You know more than I do. Why would you want to do that?" And the last thing she wanted was she wants empty vessels. They didn't want to have somebody challenging, and so that's kind of a side story. But I did that for 25 years, and all the time while implants were, going through to where we are now with our digital workflows. And I didn't want to deal with kids either. I rarely saw kids except for when I was every 3 months in Mexico at the Thousand Smiles cleft palate clinic, which I did kind of like give my time to treat kids. But in my own practice, occasionally I would see a kid of one of my patients that wanted me to see them. But as I started really, teaching the airway stuff, um, the dentists that were in there, the colleagues, even the physicians, they'd say, "Hey, that's my kid. Will you see my kid?" And so the interesting thing is, as you treat kids, there's a really interesting thing that kids that I have noticed, kids have parents. And when the parents are there and you're treating the kids and go, "I'm next." That was me when I was a kid, where they were thinking it was a genetic condition. And
Right.
so then now they treat kids. So whether you treat adults, only adults, adults have kids and they want you to treat their kids. So when I treat my adult kids, they'll say, "Will you see my kids?" Or if you're treating the kids, they'll say, "Will you see me?" So if you're getting into this, the problem that you may have, which is a good problem, is maybe if you don't want to treat the kids, then you bring on partners that could do that part of it under the same roof in your
Exactly.
practice so you can be comprehensive and treat the entire timeline. This is what I tell Barry, my teaching partner,
Rayfield.
Barry Rayfield. I said, "Barry, you need to have, a prosthodontist or restorative dentist in your practice so you guys can really, because their parents ask you to treat them, you don't because you just focus on kids. So I cannot, in good conscience, knowing the medical comorbidities, ignore that with kids because I went through that with my own kid. And I look back and read the literature, I go, oh my gosh, what a bullet we were able to dodge with our kids. And yet it's unbeknownst to more. So
Right.
that's what happens is when you have the curse of knowledge, you can't ignore it, right? I
It's
mean, that's
true.
kind of where you are right now.
I was thinking if we can circle back now, which I think we almost were there, organically to this paper
Yes.
about the upper airway volume predicts brain structure and cognitive and cognition in adolescence. This seminal paper. What do you believe should be the take-home message from the pediatricians that read this paper that really want to do something better? Uh, what would, you know, eh, we're raising our hands saying we'll help, but how do we bridge that gap where they don't understand that there are a lot of Mark Cruzes out there that will take care of these patients in a real way? And what do you think their take-home message is going to be after reading this paper? That a certain percentage of these poor kids are going to have problems. Oh well. Or are they going to be able to start making subsequent papers to talk about recommendations for long-term care and health and intervention, things like this, and where the dentists fit into that? Do you have any thoughts on that?
Yeah, I have a lot of thoughts on that. First of all, my experience has been that if the physician has a kid, they're interested. If they
Interesting.
don't or they're grown, they're less interested because everyone lives a busy life. It's not a right or a wrong. It's kind of like it's like sensory overload. I already have enough on my plate. And so I'll step back and really comment a little bit on one of the findings of this paper that I think has very probably some of the most significant ramifications is that their findings looking at this complex interplay between socioeconomic factors, brain structure, and cognitive outcomes in adolescent development was huge. So they actually, in the study, looked at socioeconomic factors. They looked
Yep.
at income, the
Race.
parents' education, the parent that was had the highest level of education. And one of the conclusions was that they found that in specific populations, there was a higher risk of snoring and having adverse brain changes. And and they tied that to socioeconomic factors. And
Right.
I would kind of disagree with them in there because of the way they looked at it is it's it's throughout. Yes, what their explanation was that if you were living in the projects, the air quality wasn't so good, more allergens, and that you might snore more as a result of that. But very affluent neighborhood where they have dogs and cats could do the same thing, right?
Exactly.
And
Yep.
so I would go back to David Gozal's study when he was at Louisville, where he looked at an entire school district, and he looked at the lowest performing kids in each class. And essentially, what they found was that that the lowest performing kids invariably had sleep disordered breathing across all socioeconomic factors. But another study he did, I think it was a sleep restriction study, that looked at kids that just had one less hour of sleep, and as a result had cognitive declines, and their functional MRIs lit up like what you see with ADD, ADHD, and that you could have a loss of up to 15 IQ points. And then there was another group, I think, out of New York from the Wall Street Journal or somebody that actually looked at and monetized how much a drop in IQ point would be per year for the rest of your life. That started looking at socioeconomic ramifications. So Karen Bonnick at NYU has also looked at this. So yes, there perhaps are some socioeconomic strata, but I'm going to argue that it's across all all socioeconomic individuals. And in fact, we know that even the most affluent in a society in the past actually suffered from more disease than the proletariats, for example,
Yeah,
because
I'm
they
just thinking of like one possible factor would be just diet. I mean, the refined foods of the ultra wealthy
the
eat
pate,
everything
the
pureed
caviar,
and soft and
yes,
wagyu steaks or whatever
exactly,
compared to the guy that's biting on the
the mutton,
the bone.
right.
It's a huge part.
Yeah, so
So
I don't know. So I kind of wanted to just bring that up, but I think you said what would the pediatrician get? Well, again, I think if they really understood the thing that they would do is they would actually pay more attention to sleep tracking, for example.
okay,
They would ask about snoring, but it would be perhaps less qualitative and more quantitative. So I'm going to argue, and I'm talk to people in school districts and administrators, and I want to spend time training them that even teachers should be asking, and maybe at the beginning of the school year, maybe doing a pediatric sleep questionnaire,
yeah,
right? So that's a little bit less qualitative. So those would be some very easy
right,
solutions that would be part of
okay,
the
but
intake.
you perfect. But what happens next?
So
So
then that
we've got all this information. We've identified these kids. What is the pediatrician supposed to do? Do they
that
typically send for a sleep study? Do they refer them to an
that
orthodontist?
would be a mistake. Yeah. So I think it's going to be a process. So now you're really getting into what the problem is, which is where I'm spending most of my time, is the way the system is set up. You're asking perfect questions, what the problems are in disease management. And it's not going to be any easy answer. And this is where policy has to change. But I think first, what you add in your intake, and then once you do have a positive, let's say a snore plus, maybe you start implementing some form of sleep screening. I think it would be unwise to send all these kids for sleep studies because this is the other part of the study that they commented on, there aren't enough resources, there aren't enough sleep labs, there aren't certainly enough pediatric sleep physicians to take on the magnitude of the problem, right? So
Right.
that's where they were suggesting that maybe looking at volumes that they would say, well, maybe the next step is you go and get this MRI to look at the volume of the airway. I think that would be a mistake.
A
I
huge
think
mistake. Yeah.
eventually they might say, I need to send you to my dentist. You know, the problem there is that most dentists, again, and that's why the airway mini residency exists, is to raise that standard and knowing how to identify the problem, how to stabilize the problem, and then if you move on, how to get into more complicated intervention. So that's the whole structure of the airway mini residency, part one, part two, and then part three. But right now, we're just in the beginning
Right.
of the early adopters, which I think is still late, that are starting to be interested in saying, okay, what could I do? And then you start working with your pediatrician. So I have a lot of pediatricians now in my community
Sure.
that refer to me, but that's not typical.
Right.
Eventually, because they've been educated, I've educated them. So I think that's what you do is you start teaming up and go to lunch with your pediatrician and say, hey, look, did you know about that? And the way you do it is you just give maybe 3 to 5 well done studies. This would be one of them. Just
Right.
say, would you mind reading this and tell me what you think? And you start the conversation.
Right.
So I think that's how you change the community and
Yeah.
communication.
And I think it would be really great. And we've talked about this a little bit too. Is we need some good, you know, some serious uh, supporters that can launch a PR campaign, not only targeted at physicians but targeted at parents and schools to raise awareness, and then have a credentialed or at least non-widget based
Yes.
referral network that people can actually get true interventions that are going to take bring their kid out of this. And I worry about setting out to a sleep study or an MRI of the volume of the airway as well, Mark, because what if it comes back, oh, there are no problems? And in one of
Well,
the,
that's exactly
it drives
that's
me
what will happen
bonkers. Right. I mean, the number of patients say, oh, yeah, I had a sleep study, I'm fine.
because this
You
is a
know
very
darn well they're
calibrated
not
research.
fine.
This is a very calibrated research study that they were very disciplined. You're not going to see that in a community hospital or
Right.
in, and so you're absolutely right to make to really look at does it translate into real world practice? And I think
Mm.
I am concerned, as you know, that there is a very shallow understanding. People think they've got a deep knowledge. They take a weekend course and it's very widget driven. You first have to really understand, what's at stake, and you have to feel comfortable with the information to really be able to make a difference in your community. So, um, yeah, I think that's part of our challenge, right? That's why we're teaming up to hopefully move the needle. I'll just maybe we'll wrap this up in
Hmm.
the last segment of our podcast that we always like to talk about. It's called This Week's Learning Moment. I'm going to share one with you, and then you could, tell me yours, but it
Sure.
just kind of honestly just came to my mind because I was going to talk about something else as we're talking here is I had a new patient yesterday that came in. And by the way, this happens very, very often. And in fact, this happened at the last study group meeting that we had, hands-on study group meeting that we had in your San Dimas facility, if you remember. But there was this patient that got referred to me by another one of my patients, who's a doctor. And he came in, and I started explaining everything, kind of went through what was going on. And he started getting emotional and tearing up on it.
Mm.
Just like with that patient, same middle-aged male patient, when they started realizing that they weren't crazy, that a lot of the problems that they were having is they couldn't breathe through the nose well, they had bad sleep, they were sleeping in a different bedroom than their spouse because of their snoring, and they were feeling fatigued and anxiety throughout the day, thinking that it's their job and everything. So I kind of explained the physiology, and that's when he started getting emotion, going, "Oh, I understand now," and it made so much sense. And one of the things that he said, because he's very connected, and he said, you, Joe Rogan needs to interview you. He says, I'm going to call one of my buddies inside. I'm going to get you on Joe Rogan. He said, also, I have connections with RFK. I need to get you connected with RFK. So for me, it's like I always am hoping for that opportunity that just comes where, it really resonated. And so part of what we teach in the Airway mini residency is to feel very comfortable to talking about it, right? Um, so that it's believable and it's not a sales pitch, right? So you're not like trying to sell something, you just explain to the patient something that they intuitively understand, and it leads to co-diagnosis with the patient and case acceptance to take care of them. And when you take care of that one person in that family, it changes positively in that whole family dynamic. And that's really what's exciting versus going in there and doing a set of veneers, right? Or even a full mouth rehab that doesn't really move the needle. Yes, it's great. We love doing that. I'm not saying that's bad, but this is a really kind of a different way of practicing. So my learning moment was really that I wanted to share with this patient that as a male. Now, it happens with females all the time because they've been in a disease management healthcare system that they'll could go to the internist and they're given a chill pill for their anxiety, maybe something else for, oh, you're depressed, let's take this Paxil. And, maybe you take some proton pump inhibitor for that, for that reflux or whatever the symptom is. For the headaches, do some Botox. For the TMD, treating things in isolation, and all of a sudden they've got a root cause understanding because in the process they've connected the dots. I didn't tell them, they already connected the dots in that process, and it creates this upwelling of emotion where the patient's very, very grateful. So my learning moment is that for this week, and that I wanted to share. What was yours?
Mine was, it's really interesting because I am treating a young man that uh, he's in the dance community, the competitive dance community, and his dance partner has significant issues. He's being treated by me, but she is not. And she approached me and said, I want to feel better like he's feeling. And I
Oh,
said, what do you mean? And she said, he's a different person since he started this intervention.
nice.
He's sleeping better. He's breathing better. He's more fun to dance with, and I think I need what he needs. And I looked down, and I've already known that. I said, "You do." She goes, "I'm."
You're right.
She said, "I'm telling my mom." So it was really cute that these
Yes.
adorable little competitors, they listen, they see the difference, and they want the intervention, they want the treatment. So
Isn't that interesting, Rich? And
yeah,
and and you would say before this, what's there to treat when I would guess, venture to guess, that those kids were probably at the top of their game in
oh
what
yeah,
they were already doing. They're already world class, right?
right.
Dancers.
Oh, absolutely,
And so then she's saying, I still want to be better. So
absolutely.
it kind of harkens back to, I think, 2, 3 podcasts ago, where we're talking about being the best expression of yourself, regardless of whether you're a gold medalist or just someone that is just average, quote unquote average, you still want to be the best expression. Yeah, I thought that's interesting. Yeah, it's very
Yeah,
cool.
and
Thanks for sharing that.
I hope that we don't go on and I said we because I want to go too.
Yeah, yeah, we'll go together
Even
for
though
sure.
I'm a little your support person right
Yeah,
next to
yeah,
you, but
no, that'd be
uh,
great.
we better hope that that takes a little while to happen because we need providers. And
Yeah,
we need educated providers out there. We need a network of qualified people that aren't just going to hand people mandibular advancement devices and do all kinds of, you know,
yeah.
shallow treatments and without understanding the entire continuum of this.
Widget driven treatment. We don't want
Right.
that.
Correct. Correct. It would be the worst thing because a Joel Rogan episode is gonna it will it'll be a viral response, and then if we don't have optimal providers available that really understand this from age minus 6, minus six
But
months
you know
old
what
today.
it'll do, Rich? I understand your concern,
I worry
but what
about
it
that.
will do is it will force policy change. So
Ah,
now everyone goes, it's kind of like what happened in 2016, 2017, the ADA passed that resolution
right, right,
mandated,
right,
prior to that, it was driving me crazy. They finally, said, okay, this is our domain. We do have to do that. This was in the throes of the AMA and the ADA fighting over who deals with sleep.
right.
Now it made it clear that we do have this role. And I'm going to say it's not to be the stepchild of a physician. In fact, we have to be the ones leading this. And so I think maybe what it does is it forces that. And you and I talked about this, I think, episode 2 about the problems in dental education, that maybe it starts changing the accreditation requirements for what a dentist should be trained in, to actually look at, a whole body evidence-based approach, if you will. So, but it's a
Wonderful.
good problem to have. We'll
Okay.
see. But that's
Th-
where the AMA comes in, the AMR comes in meanwhile.
Fantastic.
Yeah.
Wow, this has been a really great episode. I've really enjoyed it. I mean, we started with that
You too.
article, and we just went on this sort of path into various different parts of it, and now we're back to the beginning. I loved our, our, you know, our take-home messages, our learning moments, and Mark, really looking forward to next week. Do you have any previews of what we're going to do in our next podcast?
Um, I will, I've got a list of so many things we could talk
I know,
about,
right?
but we'll definitely do
Okay.
our routine and preparing and making sure that we are able to provide the best information. And if people want to learn, dentists want to learn about that, maybe you could tell them a little bit about
Yeah,
mini residency that
exactly.
give them a
Well,
deep understanding.
absolutely. We have two courses that are now open for registration. One is the AMR 3.0 session one, which is going to be, I'm looking at my calendar here to make sure I get the dates perfect. It's January 16, 17, 18, 2026. And then we're going to have a part two, which will be on May 1st, 2nd, and 3rd. These are 6 days. It'll be at our teaching center in San Dimas, California, where we run classes here all the time. Dentists from all over the world come here. And it's on our website. Uh, we're going to try to feature it in a more obvious position really soon. But right now, just go on to stevensondentalsolutions.com and get into the CE courses drop-down menu and just scroll down until you get the AMR. And I would encourage you to get on that quickly because we're going to max out in that course. And Mark and I are really busy. It's really, really hard for us to find time to teach these courses. So when they do, it's a big deal, and I look forward to seeing you at that course. I guess that's the all I can say at this moment.
Yeah, no, that's
I
great.
hope you can
Yeah.
make it.
Yeah, I hope so too. Rich, have a great rest of your week,
You too, bud.
weekend, and we'll see
Okay,
you
bud.
next week. Take
Okay,
care.
I'll see you
Take care,
next week.
brother. Okay,
Take care,
I'll
Mark.
see you. Okay,
Thanks.
bye-bye.